So hello guys, how are you doing today? So we will wait for the other students and we will start the task in a while. Thank you. So, guys, let's start our today's discussion. So, right. So, everybody can see my screen.
Yes, sir.
Oh, perfect. So, anyone in here that would like to go through the step?
A 72-year-old man comes to the office after several days of mild headache and lethargy. He also had weakness, chronic cough, and decreased appetite. He drinks 2 to 3 beers each weekend and has a 40-pack year smoking history. Temperature is 37, blood pressure is 120/80, normal pulse is 78, respiration is 24. Lungs examination show mildly prolonged expiration with
Mm,
end expiratory wheezes. Lab
mm,
results are following: HB 11.2, normal platelets 194, normal leukocyte 76, and a normal sodium 122, potassium 3.9, bicarb 24, urine nitrogen 68.6, glucose 95, osmolar plasma osmolarity 250, osmolarity urine 310. Chest X-ray revealed overinflated lungs and a 2.5 centimeter left hilar mass. Biopsy of the mass would likely show which of the following.
yeah.
So that's an obstructive disease with increased and
Mm-hmm. Okay.
expiratory reason. Smoking history is leading us to COPD.
Yeah. Basically, a patient having a COPD, but what will having if they have a higher lymph mass that are present
Hilar lymphadenopathy.
that are basically now present in COPD patients. All right. So, can you go through the laboratory results? Which of the following is the derange in it?
Sodium is less.
Perfect. So sodium is less, and the patient in is and so let's discuss it. For example, a patient is having an hyponatremia case is going on. Okay, this is abnormal. Okay, so what do you think happen in the urine osmolarity? Osmolarity in plasma is 250 millimole per kg H2O, and osmolarity of this is 310 per kg of. So whenever we take the biopsy of this patient is likely to having a COPD, but it also indicating one of the most important presentation of this is that having the decreased sodium level.
And urine osmolality is also increased.
Yeah, the urine osmolarity is also increased. So what does it mean? Decreased sodium in blood. Number one, there's a decrease. Number one, there is an increase osmolarity of urine. So what does it indicating?
So
Means
urine is being
concentrated urine
expelled.
and sodium is not being absorbed in the blood.
That's one. Wait a minute. If what the causes of the urine increase urine osmolarity, it's mean that more water is absorbing in body, retaining in the body.
So SiADH.
Yeah, we are coming to it. That's the point. So whenever there's increase osmolarity of the urine and it is the water is retention in the body, it means that ADH is secreting in it. So this water will lead to the dilution of this sodium in body. So for example, in a container, we take a fluid of water and there is a concentration of sodium that are, for example, that 135 to 145 normal range. Whenever you put a water in it and we have to increase this fluid till that, so what will happen? These one sodium will be surrounded by a large number of water molecules. So this value will be decreased. Have you got the point? So this patient is most likely probably having a euvolemic state hyponatremia due to the increased water retention in the body. This is called euvolemia. Have you got the point? So what is basically the causes of the increased ADH in the body?
Paraneoplastic syndrome in case of this question.
Yeah, perfect. So if you do a biopsy of this mass, we have taken the biopsy and want to see it will lead. So what is the most common cause of increased ADH in paraneoplastic syndromes? So which of,
SIADH.
yeah, so there will be a syndrome of inappropriate ADH. So this is ectopically secreted in lung and which malignancy?
Small cell
Small
carcinoma.
cell lung carcinoma.
Perfect. So it is released in small cell lung carcinoma. So you have got the point. I want to know one more important high yield in this concept so you can overgo the typical case of the differentiating point from the different type of tumor in the lung. So they are basically the four most important tumors that are occurring in the lung tissue. So the most important and high in incidence is adenocarcinoma. Number one, they have a adenocarcinoma. So there will be a high number of glands on biopsy. I've got the point. So whenever we look at this is the chest text, and this is the type of tumor. So there will be high glands in adenocarcinoma. And whenever we look at chest X-ray of adenocarcinoma, it will be present peripherally. So these are very high yield points. Whenever we look at chest X-ray, the adenocarcinoma will present like a periphery of it. You got the point. And the two most clinical association will be number one, patient will be have a cardiopulmonary problem. So the most common is the clubbing, and number two, any joints problem will be there. Number two, there is other that are also present in periphery of the lung. This is called large cell carcinoma. Large cell carcinoma. This is also present in the periphery. Two periphery, that adenocarcinoma, a large cell carcinoma. Its incidence is less and is a very rare carcinoma of the lung cancer. And the most common association in this, it will be the gynecomastia and galacturia. These will be the most associated common symptom with this large cell carcinoma. It will present peripherally on the chest surgery. Okay. Third and fourth will be present centrally. Like, for example, it will be having like it will be present centrally in this part. And this will be also present centrally. Okay. Number one, squamous cell carcinoma of the lung and small cell carcinoma of the lung, squamous cell and small cell. They are present centrally in the most common association with the small squamous cell carcinoma is there will be having a PTH. Ectopic release of increased PTH will lead to high calcium in the blood. Okay, it's the most powerful association is with squamous cell carcinoma. Now, what happened in us? As in this question, having a small cell carcinoma, the most common association is number one will be having a SIADH. Number two will be having the Cushing syndrome. Like, have you got the point? So this is basically the general overview of the today's topic, the lung cancer, and we'll be having a four types of most commonly occur lung tumor, adenocarcinoma, large cell carcinoma, and the small cell carcinoma, square cell carcinoma. Have you got the point till now?
Yes, sir.
Perfect. So
Yes.
this patient is having a syndrome of inappropriate ADH, which is due to the small cell carcinoma. Have you got the point? And it's the most clinical situation will present in centrally. So centrally, two most important: small cell squamous, SSSS, 2S. That is it. Okay. The third option is you have got the point.
Yes, sir.
Perfect. Now, anyone?
Okay, I
Mm,
can do it. This
yeah. Okay.
patient most likely has which of the following conditions? A
Mm-hmm.
65-year-old man comes to the
Mm-hmm.
office due to several weeks of non productive cough. The
Okay.
patient also has anorexia and unintentional weight loss. His
Mm-hmm.
medical history includes hypothyroidism due to Hashimoto thyroiditis and a
Mm-hmm.
50-pack year smoking history.
Okay.
Examination shows an enlarged right supraclavicular lymph node.
Mm-hmm.
Imaging reveals a large mediastinal mass causing tracheal deviation. The
Mm-hmm.
enlarged node is biopsied, and microscopy demonstrates clusters of small ovoid cells with scant cytoplasm and a high mitotic count. Immunohistochemical staging is positive for chromogranin. This patient most likely has which of the following conditions?
So what do you think? I want to discuss two more important high
You
important.
can small cell
Okay, so
carcinoma because it's positive for neuroendocrine cells.
small.
Perfect. 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 That's the point. But I want to tell one more diagnostic filter between adenocarcinoma and small cell carcinoma.
So this,
Adenocarcinoma.
so this is small cell carcinoma, is it?
Yeah, this is small cell carcinoma.
Okay.
Yeah. So if there's adenocarcinoma, there will be no history of smoking.
Hmm.
But smoking can increase the risk of adenocarcinoma. But if there's no smoking history, so it is less likely adenocarcinoma. No smoking history. But if smoking history is present, it will increase the risk of adenocarcinoma. But whenever a patient smokes, there is a no risk, no association of the adenocarcinoma. It is also likely to be having a patient have a non-smoker and also cause adenocarcinoma. Number one. And the small cell carcinoma, the history of smoking is it is strongly associated with history of smoking. I've got the point. So this patient having a small cell carcinoma, and that is due to the syndrome of and this one more. I think I have told you that script mode imagination critical division in large lymph. Okay, you got the point, or I want to clear it more.
So when it's adenocarcinoma, so there won't be any smoking history related to that, right? So
In adenocarcinoma.
yeah. So
Mm.
anything else that could lead us to that uh,
Yeah,
diagnosis
the
of
biopsy,
adenocarcinoma?
the
But
finding, the biopsy. So that the most important I have told you, you have to diagnose the stem on the three ways. Number one, the history. Number
yeah.
second, you will be having a radiological any findings, and second, you will be having either autopsy or biopsy, and fourthly, they will be having the examination, general physical examination, or any specific examination going on. Have you got the point? But the most important thing in large node is biopsy. So this,
Yes.
yeah, the enlarged will demonstrate a cluster of small, void, and scant cytoplasm with high meiotic count and presence of chromogranin cell. It is a typical of small cell carcinoma. So what's these are both present centrally. So why not squamous cell carcinoma? So squamous cell carcinoma are typically also present in central. These both are present in centrally. So why not it is squamous? So what happened in the you have to note the differentiating point. This is all about remembering. This will be present in squamous cell carcinoma. Okay. And adenocarcinoma, they will be having a high glands. They will be
Hmm.
mentioning of the enlarged glands. Okay.
Yeah.
And and small cell carcinoma, these things will be present. And the in papillary carcinoma, sorry, in the Hodgkin lymphoma, the most pathognomonic microscopic cell is the Reed Stenberg.
Stomach cell.
Yeah, Reed Stenberg cells that will be present in the biopsy. Okay,
Hodgkin's,
and
right, sir? For B,
and
right?
no, no, it's present in a papillary cell carcinoma. Oh, sorry, Hodgkin.
No, no, Hodgkin's.
Hodgkin. Sorry. I was confused. It is present in Hodgkin. I got the point. It is a Reed
Yeah.
Sternberg cells will be present in a Hodgkin lymphoma. In papillary thyroid carcinoma, there will be having an thyroid problem will be going on. The weight loss and hyperthyroid type of scenario will be there.
And
Okay.
some of these will be present.
Yeah, the samoma bodies. Samoma body. So what the most this in this case, so the most important thing that you have to differentiate between the small cell carcinoma and the squamous cell carcinoma. And the squamous cell carcinoma, they will be having it is also present centrally. So the most important thing in that this will be having a keratin pulse and intracell.
बैठ जा उधर बैठ जा यार बार बार नहीं उठ टूटेगा ना उधर बैठ
Sorry, doctor, can could you please you mute your mic so the system is going on. Okay, so they will be having a polygonal cells with eosinophilic cytoplasm. Okay, and there will be a well differentiated squamous cell carcinoma shows in the keratin pulse, and second you will have intracellular bridge on the light microscopy. Intracellular bridge and light microscopy. The most disgusting points in every tumor or cancer is that you have to remember the biopsy points, the high yield biopsy points. Whenever you see the high glands in adenocarcinoma, whenever you see the Ritzenberg cell, Hodgkin lymphoma, whenever you see the somoma bodies, papillary thyroid carcinoma, whenever you see the small cell cluster chromophene positive avoid cell and small high mitotic count, and squamous cell, polygonal cell which is phenic, keratin pulse, and intracellular bridging in non-light microscopy. Have you got the point? You have to remember these points. It's not the concept, it's the points that you have to remember. Have you got the point?
Yes, sir. So intracellular bridging, why is that, sir?
So endocellular bridging are due to connect one cell with another cell. It will lead,
Okay.
yeah, it will lead to the keratin pulse formation, and there will be well circumference squamous cell carcinoma, and there will be having a cluster like you will be having like that. For example, there is a well circumscribed mass over here, and it will
Uh-huh.
connect it to the another one with a well circumcised mass. There will be no irregularity between. There will be no diffusion of these. Like you will be having this intercell bridging. If there is a diffusion present in it, so this is one cell and this is another cell and irregular borders. So this will not a differentiating point. There will be a specific point going on, but don't confuse your cell in this intercellular bridging and just remember the high yield points.
I see.
Yeah. Okay.
So it will have like a well circumscribed shape, right? So the borders will be clear. That's what you're
Yeah,
saying,
they'll be
right?
well differentiated.
Oh,
So yeah, yeah.
okay. Thank you.
Okay. 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 So yeah.
55-year-old woman comes to the office due to persistent cough,
Mm-hmm.
exertional dyspnea, and recent unintentional weight loss. She has no chronic medical problems and takes no medications regularly. She has never smoked and no history of exposure to industrial pollutants. She
Mm-hmm.
works as an accountant at a large accounting firm. Vital signs are normal. Physical examination reveals decreased breath sounds and dullness to percussion at the left lung base. Imaging shows an irregular mass in the lower lobe of the left lung and a pleural effusion. A diagnostic psychosynthesis is performed and aspirated fluid and sent for evaluation. If malignancy is diagnosed, what is the likely to be following types?
So
It's
I
gonna
have
be
to.
adenocarcinoma, yes, because no smoking history and she's a female. So
Mm-hmm.
females most commonly associated with adenocarcinoma, right?
And
And
the
it's
one
base of the lung, matlab it's on the periphery, the
perfect,
mass. Yeah.
perfect, 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 perfect. I think you have cleared your point. That's adenocarcinoma. No. So you have to do the question number 4 and question number 10 that are your homework. You have to do by yourself. If you have any problem, then we can discuss it. Now, question number 5. Any volunteers?
A 50-year-old man comes to the
Mm-hmm.
clinic for evaluation prior to a left total knee arthroplasty. Medical history is significant for osteoarthritis. The
Mm-hmm.
patient does not smoke.
Okay.
Preoperative chest X-ray demonstrate a 1.5 centimeter round lesion in
Mm-hmm.
the periphery of the right upper lobe of the lung. Further
Mm-hmm.
imaging study are suggestive of a pulmonary hematoma.
Come on.
If a transthoracic biopsy were performed, which of the following microscopic feature would be most consistent with this diagnosis?
So, what do you think?
That's an
At
adenocarcinoma.
Expression of neuroendocrine markers,
So,
adenocarcinoma.
how it is adenocarcinoma? There is any gland present in it
pul-
in biopsy? Or there is any?
Biopsy.
pulmonary hematoma.
Now, this is the suggestive pulmonary hematoma. You have to talk about the pulmonary hematoma. You leave the
So actually,
adenocarcinomas.
it's related with the osteoarthritis, something related to joint leads us to adenocarcinoma.
Adenocarcinoma. No, no,
No.
There's
no.
no smoking history,
Yeah,
right?
no. Yeah, no smoking history. Yeah. The
Mm,
point is that the main point in this MCQs is that the further imaging suggests of the hematoma. So they're only talking about the hematoma. So what will be on the biopsy of the hematoma? Just simple as that.
blood. Mm,
Blood hematoma. It's basically it is the 1% in the uworld that are the miscellaneous type. So basically, the benign lung lesion that are present in, and it is asymptomatic and it is having a point less than 3 centimeter mass, but we have to do on it on exclusion basis. Okay.
Nodules of
It
cartilaginous
also,
tissue.
Mm-hmm.
sir, it also says round lesion in the periphery of the right upper lobe. So, isn't that a little misleading? Like, it gives us the impression that it's in the periphery, like adenocarcinoma, but it is not, right?
No, 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 leave it all this time. It so the further imaging suggests the pulmonary hematoma.
Hmm.
So do you
So,
have to
some
go?
sort of trauma, could it be?
No, no, it's not due to
Not really.
trauma. Not due to
It's
trauma.
Hmm.
option C,
It's
invasive mixed
a
with chemical
Basically,
hematoma.
deformation.
wait a minute. Wait a minute.
Option
For
D,
example,
cartilage.
yeah, that's one. Yeah, we have to do it on oxygen basis. For them, there's a neuroendocrine markers. So it is present in
Small cell carcinoma.
perfect
Small.
small cell carcinoma. So it's been excluded from it. So invasive nets with a keratin pulse formation.
That's squamous cell.
Sonoma
Squamous
bodies.
cell carcinoma.
Perfect. Squamous cell carcinoma. Excluded. Sheets of large pleomorphic cells.
Large cell carcinoma.
Perfect. Large pleomorphic cell is a large cell carcinoma. So atypical cells lining the alveoli without invasion. Atypical cells lining the alveoli and not without an invasion. And nodules
That's
of a cartilaginous tissue. So what do you think? What is this is? So what do you think, guys?
osteoma.
A-
Osteom.
No, no.
Atypical cell means this is cancer, not benign condition, and nodule of
Hmm?
cartilaginous tissue, as it is pulmonary hematoma. It is a benign condition, and probably option D is correct.
Yeah, D is correct, but I was talking about what's happening in
Yeah.
this condition. What will be this? What is this?
That is a benign tumor because it is not invading, so it is not malignant.
Yeah, that's the main important point. Atypical cells are there, but it's not an invasive type. And it is typically seen in adenocarcinoma in situ. Adenocarcinoma in situ. Okay? Atypical cells lining the alveoli without invasion, it is present in the adenocarcinoma that is in situ. So it is not the case of adenocarcinoma, either in situ or an invasive type. Okay? So the option left is the nodules of a cartilaginous tissue. So on the basis of exclusion, we have excluded the point 1, point 2, point 3, and point 5. So this left. So that will be a correct option. Okay. So one of our students has correctly answered the question, and he gave correctly the explanation of this question as well. Have you got the point?
So,
Yes,
what
sir.
exactly is this nodules of cartilaginous tissue? What is that condition?
Yeah. So this condition is a so basically the primary hematoma is the benign condition that are present in lung. It is due to any that are basically asymptomatic in nature. There are no any history, and it is diagnosed. It is diagnosed accidentally. Whenever you do
Oh,
it is diagnosed accidentally. There is no any history, and there is a well comprised mass is also present in it, and it's often having a calcification and grow very slowly, and it's also present in the periphery of lung. And then whenever you do the biopsy of it, so there will be you will be find a two most important thing. When you see the microscope, what is you will find the cartilage or any fat like material will be on the biopsy, or sorry, it will be on the microscopy. So you will find the cartilage and a fat like material in that point. Okay.
okay, sir. Thank you.
Oh, okay, perfect. So basically this is the one question that are in the miscellaneous type and don't know what it come in the lung cancer, but you can do it on exclusion basis as well. Okay. Yeah.
So this hematoma is actually a remnant of lung tissue. So it's like a benign condition. So we accidentally just find it.
Yeah, it's accidentally diagnosed. Yeah. So what's
The
anyone say?
72.
Can I read it?
Yeah, yeah, what?
A chest CT scan reveal a mass in the right lung. Light microscopy in the mass is shown below. A 72-year-old man come to the office due to persistent cough over the last 2 months that is occasionally associated with scant white sputum. She has also lost 4.5 kg, 10 pounds since the onset of her symptoms. The patient is an ex-smoker with 25 pack year history. She was diagnosed with mild chronic obstructive pulmonary disease several years ago, and she uses albuterol as needed for the episode of wheezing and shortness of the breath. Physical examination shows scattered wheezes by laterally. CT chest CT scan show. Sorry, I couldn't see it. Reveal a
Even,
mass
even.
in the right lung. So,
Mhm.
light microscopy of the mass. Which of the following is most likely diagnosis?
Yeah,
Adenocarcinoma of the lung,
perfect.
and then mesothelioma, pulmonary tuberculosis, and I cannot see the more options because the screen, and small
Good.
lung cell cancer and squamous cell carcinoma.
Okay. So let's come to the history. So what do you think that this is a diagnostic feature of?
Looks like adenocarcinoma from the picture.
Adenocarcinoma.
Yeah, yeah.
These
Yeah,
The,
adenocarcinoma
dilated
definitely
glands, number of
look at
glands.
that's a
Glandular pattern.
many glandular
yeah,
patterns.
yeah, yeah. That's the point.
Glandular pattern.
That's the glandular pattern that you haven't seen. The many glandular pattern that you have seen in this that you have. Oh, okay, yes. The smoking also not present. There's a woman as well. History of a woman. No any history of any TB and small cell carcinoma that are mostly present with smoking, and is a woman and non-smoker as well. So it's TB is excluded. Okay, small cell carcinoma is excluded, and if there is small cell carcinoma, there will be secondary SIDH or something like that. Neuro paraneoplastic syndromes feature will be present. If there is squamous cell carcinoma, they'll be having hypercalcemia or PTH included. Okay, so in this you have seen the multiple gland in it, like basically this is the one of the gland. This is the one of the gland that are basically invasive type. Right? These are also the glands. Okay, but normally these glands. Let's discuss the normal physiology a little bit. For example, if you want to see the normal lung biopsy, so you will see an alveoli, the blood vessels, and the little institution between them. Then alveoli, institution, and the blood vessel. It will be like it, and in them there will be a one. Sorry, there are the blood vessels, and whenever look there will be a one gland present. One gland present in that. Okay, so whenever you see the adenocarcinoma, there will be having a multiple glands that are invasive in nature. That will double, and that will cause a destruction, and it will lead to the adenocarcinoma. The multiple gland and adenomine gland is the multiple glands formation. It's a very bad prognosis of it. Have you got the point? So, on the basis of occlusion as well, and on the biopsy finding, so we have excluded mesothelioma as a very rare malignancy, and it is associated with asbestosis. I have teach in pneumoconic courses. So, whenever asbestosis is to come, the two most important CA that come to your mind. Number one, the most common one is a bronchogenic carcinoma. And if the bronchogenic carcinoma not present in the options, you can go with the mesothelioma. But the history of asbestosis is the common with the mesothelioma. Okay, pulmonary tuberculosis, there was no any history of the pulmonary tuberculosis is there, and small cell lung carcinoma, there is no any history of the biopsy findings and no any history of smoking and like that. And squamous cell carcinoma is not that much typically, but we have to go on the level of biopsy. You have to turn the lung adenocarcinoma of the lung. Have you got the point?
Yes, sir.
Okay,
Yes,
perfect.
sir.
So
So for squamous cell carcinoma, sir, other than smoking, what else is characteristic?
the squamous cell carcinoma.
Yeah.
So I have told you in squamous cell carcinoma they will be having the
Hypercalcemia.
yeah squamous cell carcinoma they will be having a hypercalcemia associated with the PTH population. And with the
Oh,
small cell carcinoma, they will be having any sign of SID, ADH, or Cushing syndrome like feature will be present in squamous cell carcinoma and in small cell carcinoma. They will be having a SIDH. In squamous cell, they will be having hypercalcemia and PTH like related symptoms.
PTH. Okay, okay.
Have you got the
Thank you,
point?
sir. Yes, sir. Thank you.
Welcome, welcome. So, mm, anyone?
I'll read it.
Yeah, yeah, go ahead.
Which of the following is the most likely cause of this patient's symptoms? A
Mm-hmm.
16-year-old man comes to the office due to progressive pain beneath his right scapula and in his right arm for the last several months. He has taken over the counter analgesics, which provide short term relief, but the pain has become more severe and awakens him at night. The
Mm.
pain is associated with numbness in his right forearm, extending up to the tips of the fourth and fifth fingers. The patient has also had a persistent non productive cough and lately has been coughing up streaks of blood. He has a history of hypertension, gastroesophageal reflux disease, and osteoarthritis. He has smoked 2 packs of cigarettes daily for more than 40 years, but recently cut down to 4 or 5 cigarettes a day. Which of the following is the most likely cause of this patient's symptoms?
So, basically, what's going on over here? You have to see progressive pain, progressive pain in the right scapula and arm. One.
Myasthenic syndrome going on?
Mm, let's discuss it. Let the numbness in right arm extending to the tips of the fourth and fifth fingers. Okay. The most important thing is that so let do it
Metastasis.
metastasis. No, no, there's no
Maybe
any
superior circle tumor, the G, because it's compressing the superior ganglion on the upper lungs.
perfect. Perfect. That's the point. So how we will do it
The
on the
Penfast tumor.
yeah. So we will do it on the basis of exclusion. So abnormal hormone secretion it is present in it mean either it is secreting an ADH. Have you got the point? Abnormal secretion of hormones. Talking about the ADH or PTH. So any sign and symptom that are not the pain and these things are not present in this
Mm.
PTH. You will be having a hypercalcemia plus high
Calcimia.
calcemia will be as well.
Mm.
Okay?
Okay.
Yeah. So what's the airway obstruction? Is it talking about the asthma
No.
or COPD? No, basically it is
No.
talking about the mass. I told you the two centrally present masses. Number one,
Small cell squamous.
perfect. These are present in the centrally. So whenever this mass is grow in size, it push the sorry the trachea and there is airway obstruction. So any masses that are present centrally will cause the airway obstruction. Have you got the point?
Yes, sir. Yes.
You have excluded this as well.
Mm.
Okay.
But so in this, it's saying
Hmm.
the mass is like below the scapula, right? But
Yeah.
so
Yeah.
does
Let's come to it. I will let you know what is going on. It is basically the problem is going on in apex. Apex.
yeah,
It is also compression on the lower brachial plexus, and the lower brachial plexus will lead to the sign and symptom of the numbness in the forearms,
normal. Mm.
and there is a pain in the right of the scapula. That is, have you got the point?
Yeah, so this is like above the clavicle, this mass, you're saying, is it?
Yeah.
So it's superior sulcus tumor?
Yes,
Yeah.
perfect.
Or central, maybe.
Yes, that's the point. It's also doing basically the three triad that's going on. Horn syndrome will be there in the sulcus tumor that you have diagnosed the patient. Then Horner syndrome will be there. Will be having the cervical involvement of the cervical sympathetic ganglion. They'll be having epithelial ptosis, myopsis, and anhidrosis. Have you got the point? The compression of this tumor on the cervical sympathetic ganglion. Number second, they will be having a spinal cord compression as well, and the shoulder pain will be present due to there is also a brachial plexus going on. So whenever this mass compresses on the lower brachial plexus, and it will lead to the shoulder pain and numbness in the fingers. Have you got the point?
Yes, sir.
So I think we have cleared our point. This is the answer. Have you got the point?
Yes, sir.
Perfect.
So if any patient comes with shoulder pain, so is it mandatory to do like a chest X-ray?
Yeah. The first no, basic line in the any problem that is going on that you have to do a chest X-ray. You have to exclude any bone deformities, anything else. Exclude the mass, one bone deformity is going on. You have to exclude that. Okay, this can be fracture as well. If a fracture
Mm.
happen, the clavicle goes downward and post on a brachial plexus, and it can also be happen in there. I got the
Right.
point.
So
You have to do a first baseline X-ray.
I see. So X-ray of the cervical spine, shoulders, and also the lungs.
Yeah, you have to do a chest X-ray. Then whenever you find a mass on the apical side of the horse, and this is called. So what's
Superior
this?
sulcus.
Basically, what this syndrome called that present in the lung episode? Do you know the special name of it?
Thoracic outlet syndrome.
Thoracic outlet syndrome. Mm-hmm. One another name,
Pancreas tumor, right?
Pancoast, yes.
Pancreas
Pancoast, yeah.
tumor.
Mm.
Yeah, she can be a Pancreas tumor, and this is a typical case of the Pancreas tumor. Okay.
So they are both the same, right? Superior sulcus tumor and the Pancoast tumor, they are both the
I
same.
think there's a little differentiating point between them, and then we will discuss it later. And let okay,
Okay.
okay. So I think we have coming to the question number 8, and let's discuss question number 9 first. Then we will come to the question number 8. Now, anyone?
Yeah.
Yeah,
A
go ahead.
50-year-old man comes to the clinic due to recent onset headache and dyspnea. The patient also says that he had a puffy face for 2 weeks with persistent dry cough. He does not
Mhm.
have any neck or shoulder pain. No other medical condition. Physical examination shows symmetrical facial swelling and conjunctival edema. Pupils are equal, round, and reactive to light. Dilated veins are noted over his neck and upper trunk. Heart and lung sounds are normal. Peripheral strength and sensation are intact. Which of the following most likely caused the symptom of this patient? Is that the superior vena cava syndrome?
Perfect. So, how you
Yes.
differentiate from the superior sulcus tumor?
That's
Is
actually superior sulcus tumor, like it's compressing the superior vena cava and leading to superior
mm,
vena cava syndrome.
mm,
The
It's
neurological symptom.
unilateral.
sorry?
Here the veins, dilated veins are noted over the neck and upper trunk, but in previous scenario there was no nothing with the edema and the veins here.
Yeah,
The
yeah, yeah.
dilated vein were not there in that scenario.
That's the point. So basically, so there is a point.
Symmetrical facial swelling and conjunctival. Symmetrical.
So who's causing the superior vena cava syndrome? So what
The
do you think?
superior sulcus tumor.
No, in options.
Mediastinal mass?
Perfect. So basically, in the superior vena cava syndrome, when there is a tumor that compresses the superior vena cava, and superior vena cava drain blood from the upper extremities and as well from head and neck. So there is a facial swelling and conjunctival edema due to the head and neck drainage, and there are distended veins in necks and upper trunks that lead to the upper arm drainage. These are compressed and superior vena cava is compressed. So
So
the
I
super
have a question.
yeah, okay.
Sir, the superior sulcus tumor, the pancreas tumor, also suppresses the superior vena cava, and doesn't that lead to superior vena cava syndrome too? That's confusing, actually.
Basically, whenever look into the anatomy of the lung apexis and the superior vena cava, basically the lung the apex of the lung is present and it is uncommon in the superior vena superior vena cava syndrome, and it is less likely in that because apex are anteriorly and it is not that much compressing the superior vena cava. So it is not likely in present in superior vena cava. Okay.
Okay, and it also the question rules out everything, the Horner syndrome too, because pupils are fine and there is no loss of sensation, right? Not
Yeah.
losing.
So it's mean that the superior sulcus tumor is excluded as well.
Yeah.
Yeah. So we have got the point.
Yes, sir.
Yeah. So basically, mediastinal mass that are pushing on the vena cava and cause the vena caval compression, and it will lead to the sign and symptom of the patient. This is a typical and it's case of the superior vena cava syndrome. Okay.
So superior vena cava syndrome will cause like um, um, edema in the upper body, right?
Yeah.
Both sides.
Yeah.
So what's the main differentiating point between that and superior sulcus tumor?
Sorry.
What is the main differentiating? What are the main differentiating symptoms then, if you
Okay.
want
Okay.
to take
Okay.
both scenarios?
Okay. Wait a minute. No neck pain and shoulder pain. No compression on the brachial plexus. Okay.
Okay.
So this apex mass will lead to the compression on the brachial plexus and it lead to the shoulder pain and numbness in the fingers, likely having a Horner syndrome on Penco's tumor. I got the point. Whenever there is superior vena cava compression, whenever a superior vena cava is compressed, so upper level of drainage system will be compressed. So this will be swelling over here.
Mm.
It will be swelling, and there will be swelling. So that is not present in the pen costume.
Oh,
I got the point.
yeah, yeah.
Yeah. So there will be a pen customer consists of the Horner syndrome and everything.
So for pancreatitis, yes, and there will be neck and shoulder pain.
Yeah. Sorry. There will be a pain history and numbness and compression in the brachial plexus.
Yeah, for pancreatitis, which is
So
also Similar to superior sulcus tumor, right?
Yeah.
Okay, okay.
Mm. So I think we have got our points. The mediastinal mass is associated with that, and it will causes the superior vena cava syndrome like symptoms. Okay.
Yes.
So let's discuss the question number 8. So anyone? So I think it's a general
Which
MC.
which of the following is most likely to lower this patient risk of lung cancer? A 52-year-old man come to the office for routine health maintenance visit. Patient feels well. He is a former cigarette smoker for 15 packs a year, but quit 10 years ago. The patient no longer has a craving or any interest in the smoking. He enjoys restoring and preserving antique paintings, spending considerable time in his basement studio. The patient has a African grey parrot and lives with his wife in a home built in 1950. Cardiovascular and pulmonary examination are normal. He expresses concern about his risk of lung cancer. Protection against which of the following is most likely to lower this patient risk of lung cancer? Benzene solvent, bird antigens,
Mhm.
bisphenol A, mold spores, and rodent gas.
It is basically the journal MCQs and miscellaneous type. So just go through the let go through the options. So what they are thinking about, what that mean, what is mean by benzalone solvent, when where it is present, birds antigen, bisphenol A, mold spores, and random gas. So basically, benzene solvent are present mostly in the cigarette smoking, and it is basically this benzene solvent is present in the metabol. It is basically the metabolite of the benzoquinones, and it is carcinogenic for that. It causes the hematological cancers. It causes the blood cancer, like, okay, and it is most common in cigarettes. Benzo. So as in this case, the patient has left the smoking, quit the smoking 10 years ago. So it's less chance of this risk of the blood cancer. So they are talking about the lung cancer. Also, they will be having a less chance of the blood cancer as well, like it leukemias types. But he quit the smoking 10 years ago, so there will be less chance of any benzaline type of hematological cancer. Like, so bird antigens, there are a bird antigen that will cause like having the like parrots and anything they are in their home, so it will cause the diseases, and spores will cause a fungus infection. So there are no that cases of mild spores are present in it. So it will having a patient with having sporus, for example, sporus spreading. It will lead to the patient to any inflammations and inflammation, and that inflammation will lead to the fibrosis. So there are no less likely they will be having an any C of lung. That will be a very low and mild spores. And in bird antigen, you will be having any. It will can cause TB, and it will cause any other uh, bird flu like symptoms, bird flu, and it will lead to that. And that is not that that can cause in lung cancer. Less likely these can cause 1%. So what is the bisphosphoryl A? So basically, it is basically a degradation product of the plastic. Whenever a plastic degrade, and it contain this plastic container like plastic like symptoms. Basically, it is not that important in. It is not that a carcinogenic in nature, and it will less likely to cause the lung CA and any risk of that. Okay, so what's anyone know what is random gas? Hmm.
This is like the byproduct of these paints, like old home they built in a long time ago. So they have this paint, and then that kind of gas is present in those houses.
Perfect.
Uranium breakdown product.
Yeah, it is basically the uranium product, and it is a basically uranium product. Whenever a uranium break, for example, if you are living in a basement for a very long period of time, so in all over the world they have uranium in a small quantity present. So whenever they have uranium, uranium will break down and lead to the gas. This gas will be dissolved in water as well. Whenever you do washing, it will be present in washing water, it will be present in toilets, it will be present everywhere. And this gas will be present in environment as well, in your basement. It will be present in basement. Okay. So whenever this is a very it will damage the DNA by random gas ionizes into the alpha radiations. This this damages our DNA. Whenever this damages our DNA, it lead to the lung CA. Okay, so this can increase the risk of lung CA, and this is when it is exposed for the long period of time. Have you got the point?
So this condition is only for houses built in the 1950s, right? So not the new
Yeah,
houses.
it's yeah. It's
What is
also
the answer now, doctor?
sorry.
The answer is it E?
Yeah, of course. The answer is C.
But here they said lower his risk. I don't know how this will lower his risk for lung cancer. I didn't get it.
He expressed a concern about his risk for the lung cancer.
Lower,
Protection against
most
protection against
likely.
No, the
This
question
is
is saying protection
the
against
question is
which?
protection against which is the protection they are looking.
protection. Okay, I didn't get. Okay, I didn't read that. Okay, now I get. Thank
Okay,
you.
that's the point.
Yeah.
I okay, perfect. I think that we have going a too much question and you have take a very strong tense on the question. Just focus on the most high yield point. It is a very this is a, like a general MCQs. You only have to know what is the benzyne solvent, Bird's antigen, bisphos, fluorine, mild spores, and random gas. What is it? Okay. So this was all about today's topic. You wrote on the lung CA. The most important, and whenever you do an CA, like malignancy and tumor on any organ system, the first more high yield point that you have to know the biopsies. In step one, they only check your biopsy finding. Are you good in biopsy? Whenever in history, 5 to 10% clue will be present, but the 90 to 80% you have to diagnose the tumor or malignancy on the biopsy. But you know the high yield points for every cancer, like small cell carcinoma, adenocarcinoma, every squamous cell carcinoma, large cell carcinoma. Have got the point. So for today, the most important thing that you have to take your first aid book and go through the lung cancers and remember all the high yield point and remember all the and also put in an Anki flashcard and do it on every week. Okay. So this was all about today, and tomorrow we will go
Excuse
through.
me, sir. Can you please just like can you explain the question one, like the very first question once again, please? I missed some of your discussion.
I
If you
think
have
you.
2 minutes.
Yeah, I have discussed this with lately. Yeah, the patient is presented to the department having a sign and symptom similar to that of to, COPD, like, but the main important point is that the patient is having a low sodium and high osmolarity in urine. So what does it mean? So high osmolarities mean that water is retaining in body, and this retention lead to the hyponatremia. Okay, so what's the causes that lead to the retention of water? So there is an increased ATH production going on. So this ATH will lead to the increased water retention, and this will lead to the hypernatremia. Have you got the point? So basically, the scenario is typically like this having a. So I have told you differential of the small cell carcinoma. Whenever a small cell carcinoma question came in your STEM, there will be present of SIADH or any Cushing's syndrome like things. We'll be having like that. Have you got the point? This is small cell carcinoma. Or whenever there is a squamous cell carcinoma present, you will be having an hypercalcemia like symptoms. And adenocarcinoma, you will be having a high glandular formation. And the large cell carcinoma is associated with symptoms like that. So large cell carcinoma will be having in any gynecomastia and galacturia like symptom. Gynecomastia and galacturia. Okay, so small cell carcinoma and the small cell carcinoma and squamous cell carcinoma present centrally, and these two are present peripherally. So have you got the point? So the question was saying that what is the most likely diagnosis of the patient? So basically, the most likely diagnosis of the patient is patient having a higher mass. So whenever you take the biopsy of it, they'll be having a small cell carcinoma, and the point that were indicating to the small cell carcinoma was that patient having a water retention and leading to the hyponatremia. So suggesting of syndrome of inappropriate ADH secretion. Have you got the point?
Yes, sir. Thank you. Thank you very much for your time.
Perfect. That's so that was all about today. So we have already this is our the trial classes going on. Okay, so those who wanted to get the videos and enroll yourself for the further UL discussion, so you have to enroll yourself as soon as possible so that we start our new system. So our new system will be renal from Monday or Tuesday on. We will start the renal, and further there will be no trial classes going on. Okay, and what's the
So,
have any, yeah.
excuse me, sir. So, one last time, sir, could you please explain the differential diagnosis for superior vena cava syndrome, Pancoast tumor, and uh, superior sulcus tumor?
So can I discuss it tomorrow because I'm having a
Oh, okay, okay,
problem going on and having a rotation and it's late.
okay,
So we will
okay, no
discuss.
problem, sir.
So what's your good
Tomorrow.
name? What's your good name?
Uh, and Tilo,
And Atilu. So
yeah,
we will discuss it tomorrow and let me know whenever I
I'll,
start the class. I will let me know that I will start with the pen tumor, so superior vena cava syndrome. Okay.
okay, sir. Thank you so
Yeah.
much. Appreciate it.
Thank you. So any question related to want to know guidance or everything, so let me know that we can do it. Related the program, any question related to program and anything else.
Yes, when is the August batch starting?
Sorry, doctor.
The August batch, when are they starting?
Yeah, I will let you know about the August batch, or August batch will be
Marathon.
start. Yeah, August batch will start from the 1st of September.
Okay.
Okay. Yeah,
What system are they starting with?
it will be from the 12 p.m. Eastern time zone, 1 p.m. Eastern. We
So
will
what
discuss it.
system?
I, I,
Cardiology?
I
Oh,
will.
okay.
We will discuss it on. I will call you now, and I will discuss it with the Analyst Marathon program. So we will talking about UL discussion program, 90 days UL discussion program. If any have any question related to 90 days UL discussion program, so let me know so that I can clear your concept. Okay. So I think that's the end of today's session, and kindly send the feedback as well in our group, so that many students are joining the session and they know what's the feedback and what's the class going on and how the class going on, and also enroll yourself in the premium group, and so that we can start our regular classes and for full flash, and we will do a 20 to 25 MCQs daily. Within 3 months we will cover the uworld in 3 months, and you can take your exam in next 4 months. So that's it. So thank you very much for the today. Hope you enjoy your session, and thank you very much. Bye bye.
Thank you, sir.
Thank you,
Bye
sir.
bye.
Bye.
Thank you so much, sir.